So bridging therapy is essentially very important for patients with severe aplastic anemia while awaiting allogeneic transplant or when a suitable donor is not immediately available. The goal is to maintain blood counts, to prevent infections and bleeding, and stabilize the patient until definitive therapy can be pursued. So first one is immunosuppressive therapy. This is best for patients without an immediate HLA matching donor, or other patients where allogeneic may not be the first choice, or patients who decline or are not fit for transplantation. The most common immunosuppressive therapy regimens are with ATG, cyclosporine, and lentrombopac. This is the standard first-line therapy. We can obtain around 60-70% of response rates at 6 months, but slow onset of action. It can take around 3 months. And up to 30% of responders may relapse. So 10-15 may develop clonal evolution. And this is the preferred option in patients with above 40 years old or without a match donor. Another option is the supportive cares. So this is the best therapy for patients who are awaiting for a transplant or response to immunosuppressive therapy, or a patients who are unfit for immunosuppressive therapy or transplantation. This includes blood transfusions, antimicrobial prophylaxis, and also growth factors. Also, another option, it can be the androgen therapy with danazol. This is an option for patients who cannot tolerate immunosuppressive therapy or require long-term transplant options. So other patients with non-severe aplastic anemia who are not transplant candidates, and also for those patients that immunosuppressive therapy has failed and another option is needed. We have to consider that this is a very limited effectiveness, so it can respond in around 50% of the cases. It has also important side effects such as virilization, fluid retention, or hepatotoxicity, and it's not a first-line option, but can be used in some selected cases. So I would say that in conclusion, bridging therapy in aplastic anemia should be tailored and based on the donor availability, the patient age, the severity of the cytopenias, and the overall fitness for transplantation. So immunosuppressive therapy remains the standard for patients lacking an immediate matching with donor. Supportive care is essential in all cases, but should be minimized to avoid transfusion-related complications. And lastly, that stem cell transplantation should not be delayed unnecessarily, especially in younger patients.